Okay, so welcome everyone. Thank you so much for joining us. Very quickly before we get started, and in the spirit of reconciliation, Alongside Families acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. My name is Pam and I'm joining you today from the land of the Ngunnawal people. So welcome to our medical information session. I'm so excited. I'm really hoping that this is the first of many, many sessions for our beautiful medical families. So tonight we're going to be hearing from Natalie from the Children's Nursing Queensland, and she's going to be sharing some of her expert knowledge about continence. So before I hand over to Natalie, I'm just going to go through some housekeeping to make sure that we all get the most out of tonight's session. So tonight's session will hopefully run for about 30 minutes. Please note that this session is being recorded, and all registered participants will receive a link to the recording within the next few business days. And Natalie has very generously agreed to share her slideshow. So the slides will also be attached to that email. To ensure a smooth experience for everyone. If you have any technical issues, please use the chat function so that I can help you out. And if you have any questions about Natalie's presentation as we move through, please use the question and answer box. Both of them are located in the bottom toolbar along your screen. And I will be monitoring both boxes, and we will address questions during the question and answer period at the end of the session, provided there's enough time. We'll see how we go. Just very quickly, as I did mention, this session is being recorded for future viewing. So just please be really mindful when asking questions or engaging in the chat that it is being recorded, and we are very mindful of everyone's privacy and confidentiality. Also, please refrain from taking any screenshots or making your own recordings. We will get everything to you in the next couple of days. Okay. Natalie, over to you.
Thanks, Pam. Hello, everybody. My name is Nat. I am a stomal therapist and nurse from Children's Nursing Queensland. I was joking to Pam just before we were sort of logged in, we were having a bit of a chat. My specialty is basically pee, poo and pus, so it's not the most glamorous, but it's a really rewarding career, and I think it's a lovely way to be able to support families. So a little bit about us and our service to get started. The first is I'm a great nurse, but I'm not very good at technology. So if there's any issues, please sing it and I will try my best. So Children's Nursing Queensland is the organisation that I work for. And it was I've partnered with Lisa, who you can see in the photo there as well. We met in 2022 working at the Children's Hospital here in Queensland. And as stomal therapists, we just realised there was a really big demand to support people who had kind of complex needs out in the community. We're finding a lot of children with, stomas, tube feeding and continence issues were coming into hospital when they really didn't need to be there. So in 2022, we launched and we started supporting people in the community, and it's been a really exciting journey and a very necessary service, we feel. We're always booked up and ready to see people. So we know that there's a big demand for these sort of specialist community services out there. So as stomal therapists, our sort of niche, like I said, pee, poo and pus. But we do a lot around kind of complex continence. So that includes, for our sort of cohorts, things like catheterization, bowel and bladder stomas, Mitrophanoffs, MACEs, transanal irrigation, those sorts of things. With that, obviously, comes the wonderful world of NDIS. So we do a lot of assessments, and they're sort of more of a comprehensive nursing assessment rather than just a tick and flick approach that traditionally has existed within that assessment space. We do lots and lots of educational workshops. So part of that role, as well as going into daycares and into service environments and basically educating people how they can safely take care of somebody who might have complex needs or some of those additional holes that we've spoken about. So I think that's a good place to sort of introduce, I guess, where our qualifications come from and what we do as service providers. we find when we talk about continence, particularly for people who are parents of children who have disabilities or medical conditions, there's a lot to talk about. And we know for continence, it's never just about wee and poo. If it was, it would typically be a really easy fix. So I think it's just something that is worth noting, that there shouldn't be any kind of parental guilt that's associated with some of our children achieving continence that little bit later. We know in our sort of Western country, you know, in a lot of the developed world, we look at kind of 2 to 3 as the kind of benchmark for continence. But that number is sort of make-believe in a lot of ways, because around the world, the age of typical continence actually varies wildly. So, you know, in some places like in Southeast Asia, they focus on elimination communication, and they can have some of the little bubs learning how to, you know, wee into a potty or over the top of a sink, and be out of, you know, nappies at a really young age. So I think it's really important to note that we talk about continence, but what it means to be continent is actually really different for everybody. So to get continent, there's lots of things we need, and all of them have to work together to essentially help us learn how to use the toilet. So these are sort of some, but there's obviously a lot more. Going through them, accessibility is a big one. If you can't access the toilet, you can't use the toilet. So that includes being able to get from where you are to the toilet quickly, as well as being able to get onto the toilet and sit on the toilet as well. So that can be challenging. You know, if you've got a child that uses mobility aids or has some form of paraplegia, how do you navigate that? It's going to be very different. They also have to be able to get dressed and undressed. So depending on the clothes that your child wears, on their fine motor skills, on their proprioceptive functioning, so the sort of their balance and coordination, they may not be able to do all of that process or some of that process as well. So that's a big step to think about. Cleaning is a big one. If you can't clean yourself, then you can't necessarily be fully continent. So cleaning includes things like actually wiping your own bottom, which is a challenging skill to master, especially if you have issues with constipation or fecal incontinence regularly. And also washing your hands too. You have to be able to go and clean your hands afterwards and make sure you're clean. Following instructions, really tricky one as well. So you've got to actually be able to kind of follow the sequence associated with toileting. So thinking about that, that includes recognizing the need to use the toilet, going into the toilet, sitting on the toilet, emptying your bowel or bladder, cleaning, putting your clothes back on. So there's a lot of sequences there, which actually can be a little bit challenging if you've got a cognitive impairment as well. And they have to be able to communicate their needs. Not all of our children use verbal communication, and that's okay. But when we have no form of communication, that makes toileting really tricky. And it's hard as a parent to implement that as well if they don't have any way of communicating that. So just some kind of considerations. So lots of reasons why we can have toileting issues. These are just some of the ones that we typically see out in the community. So the first is neurogenic bowel bladder. And the management of that is going to be really different than traditional toileting. And often the expectations about how we can get them continent might be a little bit different. So for things like neurogenic bowel bladder, that means essentially that the communication between the brain and the bowel, the bladder, just don't work, or they don't work properly enough to be able to coordinate emptying properly. And so therefore, we have to often look at other ways of emptying bowels and bladder. So things like surgery or catheters and that sort of thing, a little bit more invasive. Things like spina bifida or spinal cord injury have some unique kind of considerations. Neurological dysfunction, congenital anomalies, so things like anal rectal malformations where the child may have an anus, but it might not be in the right spot, or it might not be fully formed. That's something we come across quite often, or cloacas, where part of the genitals and the anus can be kind of fused together. That can be a challenge as well. Hirschsprung's disease is a huge one. Lots and lots and lots of kids that we support have Hirschsprung's, which basically means that you've got a lack of cells within the large bowel that cause it to push poo along. So typically with that, we have some unique kind of considerations of care and some unique problems as well that we often have to help families with. IBD is a big one. So things like colitis and Crohn's, sensory issues, absolutely massive consideration for a lot of the children that we support. So they may be things like, the toilet seat is too cold, the bathroom's too echoey, there's a daddy long legs that lives in there, it smells funny, it's dirty. The tricky thing with that is we often have to figure out what the sensory issue is with the toilet, and that's sometimes not as cut and dry as we'd like it to be. And poor interoceptive function is another thing that most of our children have issues with, which basically describes your ability to recognize internal cues. So things like hunger, thirst, the need to toilet, pain even sometimes. So a lot of our neurodiverse kind of population have quite low interoceptive functioning, and we have to find ways that we can improve that to help them recognize the need to toilet, and so they can get there quickly. I'm mindful of time, so I kind of won't go on things too long because I think questions are always a really good place to start. But very quickly, it's a very lovely picture of basic anatomy, and I always think it's kind of worth touching base on. We typically get lots of kind of questions about constipation, and so I think it's a good thing to chat about. So we eat food either down through our esophagus, or perhaps we might be peg-fed or fed via gastrostomy into our stomach. And from there, food goes all the way into our small intestines. That's this little wiggly guy here. That's also sometimes called an ileum. And the role of this part of the bowel is basically to absorb all of the nutrients that we can. So once it is all finished in here, it goes into our large bowel. And that goes in this kind of big upside down U shape. So it goes up, across, down, and then out our butts. The job of the large bowel, your colon, is basically to absorb all of the water that's in there that's left over from traveling in this ileum and make it more poo-like. So it starts off quite liquidy around here, and as it travels all the way down towards our butt, it becomes more like traditional poo. So for a lot of our children, I would say with our sort of cohort that we support, constipation is a really big issue. And typically what happens is the poo has trouble getting out of this part of the bowel, the large bowel, and it kind of can get stuck in these areas. And constipation is probably our number one issue. And when we're looking at how we support children with disabilities or medical conditions to get continent, we really have to make sure that they're not constipated first, as that sort of first step in achieving continence. This is a lovely picture. Sorry if anybody's having dinner as we chat, but I think this is a really good example to sort of show why we think that's really important. That bottom one that you can see, if we get chock full of poo, it basically pushes against all of these other parts of our body, particularly our bladder. And so if you've got a child who's constipated, you'll often have that sort of bladder dysfunction associated with it too. So when we're looking at continence, what we generally will focus on when we have children with disabilities or medical conditions is a little bit different to our sort of neurotypical or standard developing children. So the very first thing that we want to know from families is that child constipated? If they're constipated, we have to think about ways that we can manage it. And that ranges from things that are really conservative to surgery and surgical interventions, obviously done by surgeons, not by us. But that's a really big part of it before we move on to how to treat urinary incontinence. So once we know that they're not constipated, next step is to try and get their daytime wheeze sorted. So that looks different for every single kid. A lot of the time we take more of a time toileting approach, where we have set times that they go to the toilet and sit on the toilet or try and do a wee. And when we do that, we're sort of training the bladder to fill and empty at certain times. And that helps to sort of train the receptors that recognize the need to empty. And that would be how we'd sort of approach it to begin with. Again, very general in nature, every child's a little bit different, but a good sort of start time. Following that, it would be nighttime wheeze. So that will happen a lot later. And it's tricky if you've got a child with disabilities or medical conditions. You might see all these ads for, alarm therapy and things like that. there's not a huge amount of success in our sort of cohorts of children with disabilities and medical conditions with alarms. Just because of the nature of how they work, they're not always the most appropriate to use. So sometimes we look at things like medications, again, through doctors to sort of limit the urine production overnight, or other ways that we can support that. Regressions is also really common. You know, if you've got a child who has been ticking all the boxes and going to the toilet properly and then gets a bout of illness and ends up on antibiotics, you might find you get a little bit more of fecal incontinence or some other issues going on. You also might find things like UTIs or changes in environment, changes in carers, emotional dysregulation, puberty. All of those things can cause regressions as well, and they're kind of quite common, I think so. So not to be dismayed if something like that happens. It's just how we manage it and get kind of back on the horse. I think the big thing is, you know, for a lot of our cohort, we're not necessarily going to do traditional toilet training with the expectations that they're going to be fully independent and in control of their bladder and bowels, but we can often get them socially continent. And so what that kind of looks like is, you know, getting their bowels predictable. So trying to get them to poo once a day at a predictable time is a really good goal that we can support families with. And often, it often is achievable with a bit of tweaking and some time, and we might have to try a few different things to get there, but typically we can support with that. So there's lots of people that I'm sure that you're used to seeing as part of your child's medical team or treating team. I think a lot of people don't know why they need particular services or particular clinicians involved. So I always talk about why a continence nurse is a good person to have as part of your team. So this is sort of a kind of all-encompassing thing that I would think that most of us would have, whether or not it's our service or other continence nurses. Most of us would have some training. So a stomal therapist, that looks like postgraduate training. But we also do lots of courses. We go out and we do lots of professional development. We attend and present at lots of conferences as well to make sure that we are up to date with the sort of best information that's out there. We're able to assess your condition and identify sometimes potential medical issues. So things like constipation, UTIs, sometimes things like ineffective emptying that could be causing some kidney issues. We can, you know, look at those and say there may be some issues and then help escalate them and triage with your medical team to make sure that they're investigated appropriately. We can guide sometimes, I guess we can guide medications in a certain way. So we can talk about how medications work, the sort of indications for them, but we don't prescribe any of them. So we'll always say it's something that you would need to talk with your medical team about or your pharmacist, but we can certainly provide some recommendations that you can take to them for consideration. We can develop an action plan, so we can talk about steps to sort of get to where you want to be in line with what your goal is as a parent, but also what your child's goal is too, which sometimes are not always the same. Education about products and procedures. I think there's probably a million products out there that unless you know about, you know, you don't know about, that could be really useful. So I think it's always a good thing to chat, even just once a year, to your continence nurse to see if there's some new things that would be beneficial or new things that you could look at trying that could potentially make things a bit easier. Samples, so we can help you get, whether it's stool samples or urine samples, we can help you with those and complete medical procedures. So things like chape changes and catheterization, two of the common ones that we do from a continence perspective. But different specialists provide different services and knowledge. So when you see a continence specialist, there's often different ones that you might choose to engage with, or you might need to get a kind of combination of continence supports around you and your child to make sure that you're actually getting the good outcomes that you need. So some of those other supports would be people like an OT. So they're fantastic at helping with that sort of functional capacity associated with toileting, helping children, you know, figure out how to access the toilet, how to dress, how to undress, how to clean themselves. And also that sort of interoceptive skill building we were talking about earlier. So helping to get them to better identify some of those internal cues within their bodies. Physiotherapists, really important part of the team as well. they'll do a lot more diagnostic things with our children. So they can get a lot of subjective data and objective data with things like biofeedback, ultrasounds, TENS, neuromodulation, and that sort of thing. They're not always necessarily the right service for making children continent, but they're a great source often of finding that data, and they can often find where you need to go to next. GPs, obviously a very important person to have as part of your child's team, so they can diagnose, they can treat, and they can prescribe. Same with your pediatrician or other kind of doctors within that realm. Dietitians, also very, very important. A lot of our children have restricted diets or are tube fed and might not have the best nutrition and hydration that could be really optimized in their bowels. So having a good dietitian on board is always a good person to have. Pharmacists offer medical advice, and alarm therapy is not, like I mentioned earlier, it's not always a super useful tool in our cohorts, but it can be, for some of our children, part of the puzzle that helps get them dry. So funding's always an interesting one that I feel like we don't have a clear understanding on, because I'm sure we all know the NDIS changes every other day and it's hard to always get clear answers, but NDIS is just one aspect of funding. We often hear that, families will engage with us and they'll say, oh, my child is 3, so they're not entitled to get continence until they're 5 or 8 or 7. The number always changes. That's incorrect. If your child has met access for a disability and that disability is directly impacting their continence, then you can get continence funded. We just have to provide that assessment and that understanding and put the dots very close together so the NDIS can see why that's relevant. So things like spina bifida, if you've got a child with spina bifida, you should be eligible for NDIS continence supply straight off the bat, because we know that that child is going to be incontinent typically without medical intervention. And so that would be one instance where it's always funded. If, for example, you met access for, say, a hearing impairment, you may not get funded for continence supplies then. So it's all about why you met access and is your incontinence directly related to your disability. The other options that we can think about from a funding point of view would be MAS, and that's the Medical Aids Subsidy Scheme. This is a Queensland one, but I'm sure there's different elements of this throughout different states. So within Queensland, MAS will provide set products. They have kind of a list that we can choose from. So for people who are not eligible for NDIS and meet a couple of other criteria, we can fill out a MAS form and we can get them products like continence aids or catheters provided. CAPS is another one as well. That's the Continence Aids Payment Scheme, which is available nationally. And that provides a small sum of money. I think off the top of my head, it's about $350 twice a year, or about $600-700 once a year. And you can use that for continence-related supplies. So whether that is, tab-style aids, wipes, or linen, anything that kind of falls under that continence umbrella, you can use that for. Again, there's some eligibility that we would need to check first, but we can help fill out those forms as well. There's the stoma appliance scheme. So if your child has a stoma, there are ways that we can get most products needed funded through the federally funded stoma appliance scheme. With that, though, you need to be engaged with a stomal therapist, because there may be different products that are better to use. There may be forms that need to be filled out, sort of thing. Inclusion support. So we often use inclusion support through daycares or early learning centres when we're doing education. So if your child has catheters and they attend daycare, we can typically use inclusion support funding to fund a service like us to come in and provide education about things to look out for that child. So very, very diverse and constantly a moving space. It's always something that we're mindful of as well. Changes often, and so it's really important that when we're doing our assessments, that if they are for the NDIS, the explanations are really clear and that the evidence is there to really support why continence products are reasonable and necessary. So if you do want funding, you need to get a continence assessment. These would be the things that I would say all families really need to look out for. Unfortunately, we see lots of tick and flicks out there, which are not a really great way to support children with complex needs, because we know that they don't fill these lovely little boxes and these, black and white things. So tick and flick approaches, if somebody is using one of those for your child, I typically would be a little bit concerned that you might not get the sort of supports you need to really manage their complexities. It should be evidence-based. So if they're providing recommendations about products or supports or strategies that you can implement, we would be hoping that that's grounded in evidence, and there should be references or places that you can go for further information if you're wanting to find out more about those recommendations. It should identify medical red flags. So, we've kind of come across everything within the community. We've done these assessments and recognised that some children had been guzzling loads and loads of water, and that's why they were peeing 100 times a day. Encouraged them to see their doctor to do some fasting glucose tests, and they ended up having diabetes. So, when we're doing these assessments, we ask lots of questions because we know that there just might have been something that has been missed. And if we find out there's something that's been missed, and we can fix it, then hopefully that child's a lot healthier and happier as a result. Should be able to get some recommendations. That seems like a really obvious one, but based on your individual circumstances and needs. So there is no two children that we see that are the same, even when they have the same diagnosis. We're all different. We all use the toilet differently. We all learn things differently. So it really does need to be an individualized approach and not just a template that people are using. You should get resources. So, if you've got questions, whether that's handouts or information in a way that you're going to be able to access and understand, and your child is going to be able to access and understand, is something that I'd encourage you to ask for when you're getting these continence assessments done. Samples is a big one. I find it ridiculous that when your child outgrows the kind of traditional grocery store nappies or pull-ups, the expectation is you just wildly go and buy a giant pack of $40, continence aids and just pray and hope that they're going to be a good fit. And typically they're not. It takes a lot of time and money to try and find the right continence aids when you are transitioning. And that's particularly true for a lot of our children that might have physical anomalies as well. So if you've got somebody, say, with sacral agenesis, where they might have more of a barrel tummy and skinny legs, that's going to be a bit of a harder fit just to find something off the shelf that works for them. So whenever people engage with a service like ours, we talk to them about where those sorts of gaps are, and we try and provide samples that we can send out for them to try and see if they're useful. So please come to us if you want samples. Don't buy them, because we can always get them sent out nice and easy from companies. Consumable recommendations is part of that kind of samples as well, so we can't get samples of everything. But typically there will be lots of consumables that we can recommend, not just continence-wise, often also around things like incontinence-associated dermatitis, so fancy name for nappy rash, or skin integrity, or linen, or clothing that are going to keep everything held in place. So we would encourage families to kind of let us know really where those gaps are, and we talk a lot about where they might be, so we can try and find some products that might be a good fit. And services should be welcome to feedback. We don't always get it right, even when we try our hardest. And so it's great to have that feedback from families so that we can continue to develop as a service and to really identify where we might have some learning opportunities to learn more things. So I would encourage people to always provide feedback, especially if you're the parent of a child with a really rare disorder or a rare condition. Like many of our families, they might be the 1 in 5 cases internationally. And so it's really hard to find where that evidence to support that child to get continent or socially continent might be. So if you've got that sort of feedback, we would absolutely always welcome it. And last but not least, that's our lovely team. So we're a very small team. We are based, like I said, up in Queensland. A lot of what we do is via telehealth. So families, regardless of where they may be, are welcome to get in touch with us to arrange their continence assessments, and we can talk to them, via telehealth. We can troubleshoot a lot of issues via telehealth as well. But, if you've kind of got questions about continence that you don't feel comfortable sharing tonight, shoot us an email And typically we're kind of able to point people in the right direction, even if it's not us, of where they might be able to go to get some extra supports or some avenues that they might be able to look into. Hope I've kept it sort of brief, sort of.
No, thank you. That's so informative. So informative.
I'm happy to answer questions. I'll stop sharing my screen and then I might be able to see everybody else as well. Oh, lovely.
Did anyone have any questions, burning questions for Nat? Because if they do, if you want to pop it in the question and answer box, we can look at it tonight. Otherwise, we'll be sending all of this information out to everybody with the slides and all of Nat's contact details as well, so that if you've got anything that you would like to ask that's a bit more individualized and personalized, she can speak directly to your situation. No? Okay. That was so insightful. Oh, hang on. Oh, thank you. It's a thank you.
Thanks, Beck.
So insightful. So thank you so much, Natalie, for sharing your valuable insights and your expertise with us tonight. It's been really enlightening and engaging, and just loved it. And thank you to everyone who participated tonight. You guys are what makes all of this happen. So thank you. So in the next couple of days, everyone will receive an email that will have the recording from tonight's session, the presentation slides that Nat shared with us tonight, any additional resources. So Nat was talking about MASS from Queensland. I have already worked out who the New South Wales equivalent is, so that'll all be in the email for you guys. And Nat's contact details will all be in there, as well as all of the different ways that you can contact Alongside Families, so that we can continue this amazing conversation. Please stay connected with us on all socials. We're Alongside Families, Nat's at Children's Nursing Queensland, Facebook, Instagram, wherever you like to socialize online. Make sure you subscribe to our newsletter so that you can find out when all of our upcoming events are coming. There's 3 left for this term that I would highly recommend you try and jump into if you've got the opportunity. Next Monday, I'm speaking with Janet Burke about medical trauma and parents. So we're actually talking about the effects of watching our kids experience medical trauma. So our trauma, not our kids, just for something completely different. There's also a My Time next Tuesday that is you get to talk about finding joy in celebrating wins. It's one of my favorites. And on Wednesday next week, there's a Working Together with Schools workshop that a lot of families who might be having some issues with their school might find really, really helpful to help try and navigate the education system. So as always, details and registration information for that is on our website. I will pop the links into the email for all of those as well. So thank you, everybody. Enjoy the rest of your night. And I hope to see you all again soon. Thanks, Nat.
Thanks, Pam. See ya. Bye.